Buenas tardes a todos aquí en Salamanca. Buenas tardes, Salamanca. Gracias por la conexión.
Hola, buenas tardes. Buenas tardes y gracias por dejarnos participar.
Bueno, pues nada, empezamos con este encuentro, que es un encuentro muy especial por muchas cosas, pero fundamentalmente, como es lógico, el invitado de hoy es excepcional. We have now here in this hospital once again one of our best friends in the international cardiology field is Professor Alec Bahanian. Everybody knows Alec Bahanian. He has he is one of the pillars of interventional cardiology, the modern interventional cardiology. He is chief of cardiology in Paris in the Richard Hospital, and he has worked in interventional cardiology in general and in valve intervention in particular for many years. I had the privilege to learn from him many years ago when we started with the mitral valvuloplasty, first with the double balloon and then with the balloon, and it was great many years ago to receive the teaching of Alec. Alec is an excellent cardiologist, is an excellent interventionalist. He knows everything about valves, and in fact, he has been the coordinator for years of the European Society of Cardiology guidelines on valvular disease. And now he's again with us. I would like to thank Alec very much for coming and to welcome again to this hospital and to Salamanca. You have two houses in Spain at least, Salamanca and Madrid. So we will start the meeting of today, the workshop, under the we have a very nice case we performed this morning. I would like to share with all of you this case, which is now finishing the addiction of this case, and we will start with a case to be discussed by Andres. Where is Andres? So we will start with a very nice case of tricuspid dysfunction in a congenital disease. So,
hello, everybody. I have to use this one then? Okay. Probando, 1, 2, 3, probando. Un poco más lejos. A ver. Hola, 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 hola. ¿Bien de volumen? Bien, vale. Okay. So I'll be presenting a case, okay, of congenital heart disease with tricuspid valve dysplasia. It's quite complex, and actually we're still discussing what to do with the patient, so we'll be thankful for any input the audience wants to offer. And so without further ado, this is a 52-year-old male. He was diagnosed a lot of years ago of ostium secundum mitral septal defect, of an apical muscular ventricular septal defect, and a tricuspid valve dysplasia. We will see a little later something else about this valve. And he was operated when he was 10 years old with ASD and VSD closure and a tricuspid commissurotomy. The rest of the relevant medical history is arrhythmic, as is often the case with congenital heart disease. He has had several tachycardias. In 1996, he had an atypical atrial flutter, which was successfully ablated. And then in 2017, more recently, he had an isthmus-dependent atrial flutter, which was also ablated with a catheter procedure. But unfortunately, he had a recurrence in August last year. So in a second study, CTI reconnection was demonstrated, and then he was ablated again successfully this time. If we speak about bradycardias, he's also have some trouble. He had since at least 2004 a symptomatic type 1 Benkevac second-degree AV block. And, but because of this, he was studied in the cath lab with an EP study which showed a normal HV interval. And this Benkevac phenomenon was demonstrated to be super-Hessian, so it was left like that. Nowadays, he has no residual shunts, and the main problem, the main issue is the tricuspid valve, which we're going to focus on it right now. Has moderate tricuspid stenosis and severe tricuspid regurgitation. Has dilated right chambers since at least 2001 with a normal ventricular function. Well, low normal, we'll see afterwards. And he complains a lot, actually, of tiredness, of fatigue, and of shortness of breath on exertion, but he does not do any sports at all. He's only on vitamin K antagonists because of these atrial arrhythmias. And on physical examination in clinic, he had a normal BP, a heart rate of 64 beats per minute. His resting saturations are 98%. Has a raised JVP, but with a prominent V wave, we'll see because of this tricuspid regurgitation. Then heart sounds are normal, has a soft systolic murmur on the lower left sternal border, and the lungs are clear. And actually, his physical examination shows, no signs of congestion, no signs of heart failure, with no peripheral edemas and no hepatomegaly. So this is his last ECG, has sinus rhythm, 60 beats per minute, a first-degree AV block with a right bundle branch block and a left anterior hemiblock with a wide QRS of 150 milliseconds. The last Holter monitor showed normal sinus rhythm without relevant bradycardia, without relevant pauses, and without significant arrhythmias, no recurrence of the flutter. And the last exercise test showed that even though he complains a lot of tiredness and of shortness of breath on exertion, he is able to do 12 minutes of a Bruce protocol, and I think this is relevant for the decision afterwards, without significant chronotropic incompetence. So I'll show you some images. This is the 4-chamber view with and without color. You can already see that the tricuspid ring is small. It's 23, 24 millimeters. And you can see that the tricuspid valve is very abnormal. It opens with a doming movement, as if it was rheumatic, and it closes with a big prolapse. You can see the PISA in the color images of a significant tricuspid regurgitation, and also a candle flame image, which shows moderate stenosis with a mean gradient of 5 millimeters of mercury. The LV is normal in size. The walls are not thickened, and the function is low normal. The RV, on the other hand, is moderately dilated, but with low normal function, and the right atrium is severely dilated. You can see the patches from the VSD and ASD repair. You can see these very white images in the middle of the ventricular septum and in the middle of the atrial septum, which show in the color images no residual shunts. This is a close-up of the tricuspid valve. You can see the morphology. You can see that it's very, very strange. It has a very thickened annulus, which is, as I said before, 23, 24 millimeters, with a doming for the opening and a big, huge prolapse for the closing. And he was born with it, so it's a genuine tricuspid dysplasia with, let's see. So in summary, has no residual shunts. The RV is moderately dilated with mildly or low normal systolic function. TAPSI is 15, and had some anterograde Doppler wave on the outflow tract, which suggested a restrictive physiology. And the RA is severely dilated with a severely dilated coronary sinus as well. And the tricuspid regurgitation was informed as severe with a moderate stenosis. So as I said, mean gradient is 5 and the ring is 24. This is the MRI. This is the right two-chamber view. It's more or less same kind of images, and this is not working, but it's very similar to the echo actually. But what's interesting is that there is a huge late gadolinium enhancement all around the atrium. You can see it in the fourth chamber image, and also in the short axis you can see that most of the RV has now enhancement with fibrosis. So this is the summary of the MRI with no residual chance. The QPQS calculated by MRI was 1.06. The LV is only mildly dilated with mildly impaired systolic function. Has a discrete point of late gadolinium enhancement apical, which has actually we have no explanation for that, because as you will see later, the coronary arteries were normal. The RV is dilated with low normal systolic function. And the right atrium is severely dilated. You have the numbers down there. And this is the hemodynamical study, the right cath. You can see this is the angiogram. You'll see that the opening is very pathological and the regurgitation looks significant. And here I showed you an image of the coronary arteries to show you that they are completely normal with no stenosis. We did a hemodynamical study which showed actually that the basal pressures were quite low, were absolutely normal. You can see that the right atrium is 7, the end diastolic right ventricle pressure is 4, the pulmonary artery pressures are normal too, the wedge is normal too, 3, and the transpulmonary gradient is normal. And the mean AD to VD gradient, so to define the stenosis, was 5 millimeters, the same as the echo. So it's a moderate stenosis. But when we did a volume challenge with a liter of physio with volume, you can see that the end diastolic pressures, even though it has a severe regurgitation, they go up really, really quickly and significantly, up to 20 in the case of the RV, and also in the case of the LV, they go quite up to 15 millimeters of mercury. You can see that the cardiac index is above 2, so it's sufficient. It has no significant pulmonary hypertension, of course, and the tricuspid ring measured by angiography was 23 millimeters. So, well, in case anyone was wondering, the laboratory is normal, of course. So in summary, we have a 52-year-old male with a closed ASD, a closed VSD with no residual shunts, has a successful radiofrequency ablation of several lateral flutters, nowadays is in sinus rhythm, has a second-degree type 1 AV block, but with no significant chronotropic incompetence and no pauses, has a dysplastic tricuspid valve that has moderate stenosis and severe regurgitation, and with evidence of right ventricular restrictive physiology, but with normal filling pressures basally. And the functional class, when we evaluated with an exercise test, is objectively 1/4, but still the patient complains a lot. So we have 3 groups of questions we would like to discuss with you. The first one is there an indication for an intervention on the tricuspid valve at this moment with normal pressures with a functional class 1? If not, what kind of things are we going to look for in the follow-up to decide when is the moment to intervene this patient? If we finally decide on a tricuspid valve intervention, is a percutaneous approach feasible with that kind of dysplasia, with that kind of ring? What kind of tests and what kind of measures would you like to know or to have before deciding this? And the final question, and probably the more difficult for me, is how does this restrictive physiology of the RV influence this decision? It could be futile. Could we have high filling pressures with right heart failure despite solving the TR? Or an intervention on the tricuspid valve will be useful to prevent right heart failure in this patient? And is this restrictive physiology and this RV, which is not that good, is this relevant for the surgical versus percutaneous decision? So I don't have the answers. So I would like to know your inputs and your opinions. I don't think anyone has the perfect and specific answers, and I don't think there are many cases like this one, but...
Andres. The case is open for discussion. Salamanca, what do you think?
We are like Andres, so I don't have the answer. So I will talk with the patient about the clinical, and I will talk with him with the risks of the surgery. And I don't know. I think I will wait. I will wait for some months to show the evolution, because I think there are some doubts about the intervention, because there is a second intervention, and my first choice it would be the surgery one. I think the valve. I'm not an expert, but I think it's quite difficult to the percutaneous team to treat the valve. But I don't know the answer. I don't know if anybody in the room want to say anything more.
So
let's what Alex say us about this clinical case.
Alec, your turn.
Okay, can you show the questions?
Yes.
Just show the questions. So Paco kindly said that I was involved in the guidelines, and this case shows that the guidelines do not give the answer to every single patient. That's the first point. And I'd like to congratulate you for the very nice presentation. So I start, since I don't have the answer, I'll be kind with you. Well, it's something I don't know well, and I think it's a very complex gooch, and the gooch are special people. So I guess you spoke with the gooch, your gooch team.
Yeah.
Do they have, an explanation for the clinical background of this patient?
All the good team is here.
Because it's typically a gooch patient, so they should answer.
Raquel and the rest of the team.
So.
We are not very sure what the symptoms are. We don't think it's because of chronotropic incompetence, but we do think that this restrictive physiology of the right ventricle is the main problem of the patient. But having said this, if we think he has severe tricuspid regurgitation, can we improve something? Doing something to the tricuspid valve? And for us, with this kind of right ventricle, the surgery is high risk, probably, because coming out of the pump for these ventricles, there's a high risk of liver failure, right ventricle failure. So that's why we were thinking, if we know it's a native ring, but could we think about putting something percutaneous on that ring that luckily for he is small?
Yeah. Okay, so if we start, well, we don't have a clear explanation of the pathology. That's the first point. Before trying to tackle something, it's necessary to know who is the enemy. Who is the enemy? So here we don't know the enemy, really. That's the first point. Second point, this guy has a severe tricuspid regurg. I think everybody agrees. Severe primary tricuspid regurgitation, organic. But he has also an RV problem.
Yes.
And we see it on the MRI. We clearly see it on the MRI. Something is getting really wrong in this RV. Not that much the systolic function.
That's it.
But in point of fact, who is the echo person? How to evaluate the right ventricle function in a patient with severe TR?
That's
I
it.
must say that is not easy.
That's it.
I think the main enemy here, if I had to choose, is probably related to whatever happened at the time of one of the prior surgeries he went on. What we're seeing in the LV apex, and probably part of what we're seeing in the RV fibrosis, is mostly probably related to some something went wrong with cardioprotection at the time of the previous surgery. So I'm not sure that that degree of scarring is related to the time course of the valvular disease. Probably it's more, so I think probably the enemy is not at this point caused by the valvular lesion per se. Now, how that's a terrible question. I'm not sure I can give you an answer. How can we tackle RV function in the presence of severe TR? That's, I mean, I don't know. I wouldn't put my hand on fire saying this RV systolic function is normal. By no means. Looking at the late gadolinium enhancement images, despite we're looking at normal EF in the movies. So.
You agree that the TAPS is not the ideal way to assess in this patient. MRI volume, etc. It is extrapolated from the gooch, and we try to use it for the valve, but it's mostly in the gooch that you put some threshold, so we don't know exactly where it is. So let's say he has a complex congenital disease, which is, well, maybe quite well corrected, except the tricuspid. For the RV, I think your explanation could be satisfactory. After several surgery, it might be a scar. It might be a scar. That's an explanation. So he also has a CV organic TR. We said that. Very unusual. Very unusual because he has a small ring and some sort of
free tissue going up and down.
Yeah, exactly. Now, the easy answer to me is he does not show symptoms in a very high-level exercise test because this man is very young. He's only 50. This man is very young. He's only 50, but he is able to exercise much.
Yes.
But that is a drama with a tricuspid because, you know, it's not always easy to know, but you have other objective signs. RV function is not normal, but it's not catastrophic.
Not terrible.
You have pressures.
Normal feeling pressures, basically, which are also important.
Cardiac output. You did a
adequate?
fit.
Yes.
It's not catastrophic. It's low, but not that low. So I'll be like the friends in Salamanca. I think I'll be very cautious.
Very cautious.
And wait. So surgery. I don't know if there is any surgeon in the room. No, we don't have surgeon. So it's easy to say that surgery is probably very high risk. Very high risk because we do not know is a tricuspid regurg, is a chicken or the egg. Huh? Most likely it is the egg.
Probably.
Most likely it is only the egg. So that's not a good thing. Very high risk. And the surgeon, is he able to repair such a valve? I don't know.
Probably not.
I don't know. Because if he puts a valve in such a small ring, we are going to result in some degree of stenosis. So
probably
I think surgery, let's forget. Percutaneous. So, well, it's quite embarrassing because the total experience of transcatheter percutaneous in the tricuspid is said to be 500-600 cases. Good. Done 90% in Germany. And what are the publications? On 20, on 60, etc. There is a European multi-center registry, and I did not see the last presentation at PCR, but it was 200 cases among 11 centers within 2 years, which shows how many, you know, very, very little experience. The global approaches are the valve implantation. To my knowledge, there is probably around 10 cases done with the guy from South America, I don't remember the name, but Navia, the Navigate valve. Well, it seems doable, but the problem is how to anchor, because usually the rings are very large, and the tricuspid ring is not a mitral ring, so it's very, very difficult to anchor. So it's an issue, and when you put this valve, when you completely block the TR, we don't know what will happen to this
RV.
To this RV, and this valve you cannot take them out. So it's impossible to envisage that. What do you have else? You have the completely crazy solution, which is to put a stented valve in superior vena cava, inferior vena cava. But I think the fatality at 1 year is 80%. So let's say probably
not the best idea.
a better survival without anything. You have the completely crazy story. It is a form, I hope the friends from Edwards are not there, but you have a regurgitant orifice. In order to improve it, you inflate a balloon in the middle of the regurgitant orifice. So there is less regurgitation because there is a balloon in the middle. The results are, reported on 20, 30 patients. It's not without risk because you have to anchor the thing in the RV apex. What is good here, it does not, the final TR is not 0. Final TR is you go from severe to at least moderate to severe. But this doesn't work. You have the mitra clip, but here the mitra clip, I do not know if it is doable. The total experience is, I told you, reported is probably 60, something like that, cases. Patients feel a little bit better. TR goes from extreme to severe, or extreme to moderate, and we don't have follow-up, and we don't have good studies on the RV. That is a big problem. Here, the thing which could be against, there are two things to me. The ring is small. The ring is small, so the valve area could be relatively small. And also, is it possible to grasp this thing with a mitra clip? Really, I have no personal experience. We did one case only. I have no personal experience. I think it will be difficult.
And also the risk of stenosis after.
Yeah, I think we should not do because of the ring. It's too small. The other approach, which to me is the best, but I'm biased, because we are very much involved in this, is the ring annuloplasty with a cardioband system. The cardioband system. But here, also the ring is not really the problem.
That's it.
And you have an organic problem on the leaflet problem. So if you decrease a little bit more the ring, if you leave the leaflet problem, you are not playing the right game. So, and the rest, it's a completely crazy story, better not to speak. So I think because we are not sure about the etiology, we are pretty sure that the RV is not very bad, but it is very strange. The tricuspid is probably an important player, but not the first row. The patient is clearly very not very symptomatic at all. Only quite okay. And we have no satisfactory option to offer to him. I would let him go. Maybe we can try something, the name is Lasix, which is probably less risky than valve replacement or percutaneous treatment. We can see what it's saying. I would also like to have in-depth opinion of the arrhythmia people. If they think something can be done to improve.
That was discussed, but we arrived to the conclusion that it wasn't the main issue there.
No, but let's say, here we do not find a solution for the total. So is it possible to improve him a little bit by something on the arrhythmia field? I don't know. A bit of diuretic, why not? Why not? It's not absolutely crazy. And follow him. How to follow him? Clinically, for sure. Clinically, for sure. Echo will be interesting. MRI, well, in the guidelines, we did not consider this patient.
Of course.
For sure. But if you have a primary TR, patient is asymptomatic, one reason to consider surgery is not a grade 1, but is some RV dysfunction or deterioration of RV. This appeared in the most recent guideline. It could be an indication for conventional surgery if the surgery is not very high risk. But here, surgery is very high risk. So all these things, all this reasoning, to me, pleads in favor of what the colleague from
wait and see and pills.
Wait and see.
Well, this problem is out of my knowledge, but I am following the discussion of Dr. Baganian, and I think it's very intense to follow him, but I really cannot to apport any question.
I would ask you, I mean, it's pretty remarkable that RA pressure is 5 at rest, severe TR, severe stenosis, and some sort of subtle impaired diastolic dysfunction, which is probably true. So could you think it, or 7, could you think it could be useful to, I mean, in order to follow up or eventually at one stage do some exercise hemodynamics to see what happens with this patient, or you think that it's not going to help you that much?
Well, it's a very good question. Thank you for asking me. You know, Amadeo Betriu used to say, with such friends, you don't need enemies. No, but, well, I think there are no data at all, to my knowledge, on including the stress hemodynamics in the indication in a patient with tricuspid regurg. So this one is so high risk for any intervention. Well, I probably won't do it. But from your point, you agree the tricuspid regurg is severe? Yeah. You agree with that? But may I ask you a question? Because here we're in Madrid, and Pepe Zamorano published a paper with Becky Hahn introducing 2 new degrees, the torrential and the massive, on top of the severe, moderate, and what do you feel about that? No, it's difficult because you are in Madrid, but...
Thank you for the question. You're a good friend.
I must say, I give you my opinion.
I think with 4 degrees we are enough.
Far enough. Because to me the clinical outcome of severe is so catastrophic, it doesn't make sense to go from more than that to that. Okay.
So finally, let's wait. No?
Yes, actually, that's what we're doing, because for me, the main problem is not waiting now with these pressures and these exercise tests. The main problem is when 2 years or 3 years from now, we have high feeling pressures, bad exercise tests, already on Lasix, and then what? But we'll see. We'll see.
In medicine, we have enough with the current problem.
That's it. Okay, so thank you very much.
Thank you very much, Andres. Thank you. It was excellent presentation and discussion. Comments or questions from Salamanca?
No questions. No questions. Just it's a problem of the future. But we don't know what will the future prepare to us. So let's wait.
So let's move to the next case. I think that is not still available. 5 minutes. So we can continue with another case. Okay. Yeah. Felipe.
¿Este?
The first time we discussed about this patient, some people supported the possibility of doing interlink procedure.
Parece un vendedor de pizza. So, hello everyone. I'm going to start with my case. I call it, What features really influence the decision-making in mitral ring degeneration? So let's start. I'm going to present like two cases at the same time. Both are very similar but different at the same time. And we've taken different decisions in each one. We want the expert to tell us if he does agree with us, if we would have done something different, anything. So the first patient is patient number 1. He's a male, 75-year-old, and he's got a cardiac history since 2008, mixed etiology, dilated cardiomyopathy, both valvular and ischemic. 10 years ago, he had 3 vessel disease with moderate left ventricular ejection fraction, 35%, and he underwent 3-stent implantation. He did well until 2014, which actually 6 years later, where severe mitral regurgitation was diagnosed. He had still an LVF of 35% and moderate aortic stenosis. So the heart team decided to undergo surgery, and he did undergo a biological bioprosthesis in the aortic position, a trifecta number 24, and a mitral ring that I've just talked to the surgeon. He just told me this, also a Carpentier number 28. And also a posterior papillary muscle repositioning, because mainly the mechanism was ischemic bitethering of the posterior papillary muscle. So he just stayed 2 years okay. Afterwards, in 2016, mitral ring dehiscence posterior was diagnosed. So it was decided to undergo a re-op and with reparation of this posterior dehiscence in the ring. And that's mainly his cardiac history. Patient number 2 is 2 years younger. He's 73, and he does have also valvular and ischemic cardiomyopathy. 3 years ago, 2015, he was diagnosed of severe mitral regurgitation, mainly organic, but secondary to a ruptured cord, which was considered to be ischemic because the patient had left main and 2 vessel disease. He had a chronic total occlusion in the RCA and the circumflex, and a severe stenosis of left main. So the heart team decided to undergo surgery, both revascularization and prosthesis. So triple bypass with a Lima to the LAD and 2 saphenous grafts to the RCA and the circ were implanted, and a Carpentier number 26. Also, it is considered to have residual, at least moderate MR after surgery, but he did well. Of course, the 2 patients have a lot of medical history. Dr. Elizabeth from Salamanca taught us that this is called in Spanish puritos. So these 2 puritos, they both have atrial fibrillation. They both have COPD, moderate, no oxygen at home, but they do have moderate COPD. They have chronic kidney disease. Patient number 1 with a GFR of 55 and patient number 2 with a GFR of 45. They've got vascular extracardiac disease, stroke, patient number 1 in 2003 without sequels, and peripheral artery disease, patient number 2. And patient number 2, which is actually 2 years younger and does have normal ejection fraction, which is important, he has 2 medical records that I think do matter. He did have a laryngeal cancer that underwent surgery in full remission, and in 2015 after surgery, he had a severe GI bleeding that forced us to interrupt warfarin. So he was just treated with clopidogrel, doing well without any further bleeding events, but he does not tolerate anticoagulation regimes. So both patients were admitted here in our department in the last 2 months for the same reason, heart failure, and the history is pretty much the same. Patient number 1 does have same echocardiogram we've been saying previously, 35% ejection fraction. We did a coronary angiography that showed us that the 3 vessel disease treated with stents 10 years ago were okay. He did have moderate small vessel disease with diffuse atherosclerosis, but not, and the epicardial arteries were okay. And he did underwent TOE, which showed us that the patient had a severe restriction of the posterior leaflet, the one who was repaired in the last time because of a dehiscence, and a very eccentric MR, mitral regurgitation, that was considered to be severe. You can see it pretty much better here in the 3D echocardiogram, where you see this gap in the posterior leaflet that leads to a severe MR. So this is the patient with moderate LV dysfunction and with 2 surgeries previously. Patient number 2, he still has normal ejection fraction. You can see at the transthoracic echocardiogram that it seems that he does have another significant mitral regurgitation. In this case, because of his renal impairment, he did not underwent a new angiogram. So we performed a CT scan that showed a complete occlusion of this saphenous vein graft to the right coronary artery, which was already occluded, but the lima and the saphenous grafts to the circ were patent. And he underwent, obviously, another TOE, where you can see at this time severe displacement of the coaptation point of both leaflets, with a moderate thickening of the anterior and posterior and slight restriction of the posterior that leads to a significant mitral regurgitation. So these are the 2 patients. The Euro score of both is similar. Mainly patient number 1 has 1 point more Euro score and STS score than patient number 2, but both percentage are really high. So both have severe degenerations of mitral rings. They have a lot of medical history. The surgical risk is pretty high, and they were presenting the heart team last week, and one patient was decided to undergo a new surgery, and the other one was decided to undergo a mitral TAVR. So our question to the expert is, do you agree with our decision? Would you have done anything different? What treatment strategy do you think is better for each one? Do you think that TAVR, mitral TAVR with current results is a real option for high-risk patients which are not, which do not have a formal contraindication to surgery? And mainly what really interested me is what clinical or echocardiographic features may force you to decide one or the other strategy according to whatever size, rigidity, LBF, right ventricular function, whatever. Which one do you think really matters in these particular cases?
Okay, well, that's once again an easy case. Okay. Is it possible to go to the first slide? The first one. When you show the clinical history of the very first one, before. Okay, next, okay. So if we start, well, grossly, the situation is hundreds of patients have been reported. You saw that in the literature from registry with valve in ring, TAVI valve in rings. The results are slightly less favorable than the valve in valve, but still it is doable. So we don't have a large experience, very limited follow-up. That's it. And we published our experience, well, I think last month, something like that. It was not perfect, but very little experience, but it's doable. So patient one is clearly a patient who has symptoms. He had heart failure.
Both have symptoms, yeah.
You need to do something if any intervention is not futile. So he has some renal insufficiency. He's 75. Was he active? Yeah?
Yeah.
Active. You have some COPD, but I think not much. He had some renal insufficiency. Okay, but the major issue, which is not captured by the scores, is that it will be the third operation. And there is a real limitation. It's very nice to score him, but how many patients like that were in the control population from which Euroscore and STS score were derived? 1, 0, 2. So I think really that's what we try to convey, the message we try to convey. The score may help, but we should never ever base a decision in such patients on score which were based from population of patients at low or maximum moderate risk. So let's say, but surgery is very risky here because it will be a third operation, LV is not good. So this pushes us to consider to do something percutaneous. At this stage, we have two options. One option could be to do a mitral clip. Why not? To do a mitral clip. I don't know the valve area.
I think it was like 1.8.
1.8, so clearly is not a candidate for mitral clip. You know that mitral clip should be over 3, ideally over 4, so it's not a candidate for mitral clip. And also the experience of mitral clip in patients with MR after surgical ring annuloplasty is very important in Germany probably, but not reported. So we cannot base a judgment. So the option is to consider putting a valve in. Putting a valve in, what we usually do, first have a look at the ring. So this one is a semi-rigid, it's not a rigid. It's semi-rigid, yeah. So it's doable in a semi-rigid or even in a closed groove, etc., but not in classic. Fortunately, we don't see any more patient with, we never seen a classic in mitral position, so it's not a problem. We don't do it also in patient with posterior rings only. It happened, at least in Paris, Professor Carpentier used to cut a couple of rings. We cannot do that because if you do that, you may have LVOT obstruction. So that's the problem. So then the issue is the size. And here we have
28.
Yeah, 28, so it could accommodate a 26, I think. So if you can accommodate, you can check, if you can accommodate at least 26, and I guess a 28 should accommodate 26, you can go with that. You can go 28, yeah. You can go with that. This one says no, we'll put a 26 in, definitely. You put a 26 in, and really I think you can put a 26. The story is you'll have a satisfactory hemodynamic. That is to say, you are ready to accept some gradient around 5, something like that, no MR. So I would encourage you to use a 26 in such case, more than a 23. Because 23, you end up with residual gradient, which are really very important. You end up with stenosis. So the problem here could be the risk of LVOT obstruction. And that is what happened. That was a big difference between valve in ring and valve in valve. There were two different. The positioning and the anchoring was more difficult. The positioning was more difficult. You have to be on the right spot. And also the risk of LVOT obstruction due to the anterior leaflet. You push the anterior leaflet. We are going to see that in the other case. You push the anterior leaflet, which obstructs the LVOT. So here, what is missing is, do you have a very small LV cavity? Probably not.
No, not in this case.
Has a ischemic cardiomyopathy, large ventricle, probably not, but you have to look at it. You need to see the automitral angle, and the way to see that is to do CT. So you have to do a CT. You should see the anterior leaflet. Anterior leaflet looks, I'm not an echo person, but the anterior leaflet looks quite okay. It's big but not enlarged, not calcified. So here I won't be very much concerned by the, but I think you should do a CT before to measure the angle, and then probably is an acceptable candidate. Probably is an acceptable candidate. Because we have a patient with symptoms, the CV MR is an important thing, and it seems to be amenable to a valve in ring. Of course, the complication, it might have complication. The transeptal approach is the most, most pleasant, is doable. So you're working this morning, you can do that, no problem. Does he has, I didn't see, he has a tricuspid regurg or not?
Moderate.
Moderate.
Yeah.
So, of course, you leave the tricuspid alone in this case, but it's acceptable also because here you are doing some palliation, so I would accept it. And the rest, of course, you have to continue with anticoagulation because we do not know what will happen in terms of thrombotic complication in this patient. What is advised is to give at least 3, maybe 6 months of Coumadin and to follow them very carefully. We don't know, but at least 3, even 6 months is better. Secondary migration of the valve might happen. We saw, I think, one case in a MAC, not in a ring. We saw one case in a MAC, so it requires a regular follow-up, probably an echo twice a year, things like that. And that's it. So this one, except if you have another opinion, I would probably go for it.
Okay. You wouldn't prefer a transapical approach, right?
Well, you know, now I think people are moving from transapical to transeptal. I think we did the first transeptal in this indication. The first case was done by a surgeon in Leiden. He went transapical. But it is shown for TAVI that transapical kills more patients than transeptal. And here you are playing with very large, not that thick ventricle, and we do not know what will be the price to pay of having a big scar.
35.
Yeah. So I won't take the risk, really. I think you have the skills to do the transeptal. You go in the apex, you do the same thing. The risk of ASD is, well, not virtual. There will be a tear, there will be a shunt, but as long as but you don't need. I think as long as you don't have a severe right to left shunt, you can be okay and follow the patient. If you have a severe TR, be careful. You'll see immediately on the table in the cath lab, anesthesiologist will say, oh, patient is getting hypoxemic.
Of course.
And you see the TR going through the hole. But if it's left to right, you can leave it. It's very good to lower the pressure. No, I mean, to me that's not an issue. So the other one, patient 2 is more of a concern. Patient 2 is more of a concern because this one is definitely at a very high risk to me also for surgery. This one is an organic. An organic. Severe TR symptoms, so I would consider that it's an indication for intervention. Now he has a comorbidity also, but he has a problem. He has a triple bypass. So I'd like to see where are the bypasses by CT. If the bypasses are crossing just in the middle, it's a real issue.
There was not a problem at all with the lima to the LAD.
It's lateral.
Yeah.
And the others?
I do not know. I don't remember what happened with the Safen graft to the surgery.
It's quite interesting to see where they are.
But the lima was okay.
The lima is okay. It's lateral. You are pretty okay. But let's say it's an issue for a redo. Huh? It's a major issue for a redo. This one, as we discussed earlier, 26 is a problem. This dirty machine says 20, but I don't trust that. But at least you can put a 23. But 23, you end up with a residual gradient. So here, if the surgeon is not scared, yes, the surgeons are never scared, that's the problem. And if they are scared, they are not good surgeons. Surgeons who think too much, they are not good surgeons. So here is a surgeon not too scared to go for surgery. I would probably consider going for surgery in this patient because you are not going to offer him very good high hemodynamics. But if the surgeon says, well, I'm going to kill the patient because I'm going to destroy the bypass when opening, of course you'll have to stay with a 23 and put a 23 transcatheter. But if the surgeons are not scared, but here you need a good CT to see the bypass. So this one, I'd be a bit more reluctant.
Knowing in relation with this case, but what is your experience at rupturing the ring?
Rupturing, we have no experience. I think, well, you mean the risk of rupture?
No.
Volunteer.
Volunteer
I don't know. We discussed that together. I think there are 2 cases of rupturing bioprosthesis on purpose to enlarge. Rupturing a ring, I don't know if it's possible. I don't know if it's possible. I probably won't do that. Because I'm not aware of any experience. Rupturing the aortic, there is a limited experience. We do not know exactly how much we gain, but it has been done repeatedly, and people say, well, it is doable. Rupturing a mitral, I saw 2 cases as far as I know. But yeah, I'll go for a 23 regularly. So
Questions from Salamanca, comments?
No, we also think that they are both patients of high risk. We don't know what we will do here in Salamanca. The first choice, we will talk with our heart team, what the opinion of the surgeons. We have the experience of 2 patients. We have a percutaneous treatment in valve ring, and they have a very good response, and they are quite well now. So we will do like in Madrid. So our first choice was the surgery one, and if our surgeons tell us they are of high risk, we'll go to the percutaneous treatment. I don't know what are we going to do with this patient. Are we going to do a mitral clip or a percutaneous valve in ring?
In our system, we decided to do a valve in ring in the first patient and surgery in the second patient.
Okay.
Because the surgeons said that he could do it with no problem in the second patient.
I think, well, as far as I know, the mitral clip in rings, they have very limited experience, not reported really. And here you told us that the mitral valve area is 1.8. So clearly we are going to end with mitral stenosis. So it's not good. But what is the mechanism of the MR in the second patient, in your opinion?
It's a very strange, it's a double mechanism because there's not it's not coupled, the direction of the jet with what you see of the prolapse. Can you put back ¿podemos poner las diapositivas?
Ya las tenía puestas.
You see, if you look at the echo, you see a prolapse up there, a pseudo prolapse of the lateral leaflet there. Then you would expect your jet going more towards the septum, but the jet is going lateral. So I think it's a double restriction at some point of the leaflet most septal, and then a prolapse. It's a double mechanism, but definitely I wouldn't do anything with the. I mean, there's a large prolapse of the posterior leaflet that you see in the first image, but then the jet is not going towards the septum. So there must be a restrictive motion in the anterior leaflet, right? So I would never try to clip this, by no means clip this valve, and ask the surgeons if they go into the operating room to remove the ring and put a prosthesis. That would be my suggestion.
But we know that most probably the prosthesis will be quite small, huh? Yeah. But anyway, that's the best we can get. Yeah.
It's one question for the expert. When looking at the CT and the echo and trying to predict LV obstruction, there's 2 tools that some people are using. One is simulation software, and the other is 3D printing. Do you rely in any of these tools?
Well, 3D printing, we are just sending a case to a group. It's FEOPS, maybe you know this company. What we have is a fantastic Spanish girl, Marina Urena Alcazar, who does a simulation in the radiology department. And, well, it's quite okay. It's quite okay. So she does a simulation, and usually they're able to predict quite accurately what will happen with the regular things. But you know, if you look one by one to all the predictors, if no predictor is present, you are safe. If you have one or two predictors, it's very important to do the simulation, but of course you always balance with the clinical presentation and the alternative. So 3D printing, it will come, no doubt, but it's not routine. But with good old simulation, with conventional CT, you can predict quite well. That's very important. That's very important. It has to be validated, this 3D printing. It's not really validated in large number of patients, and it's mostly used with a new valve, and not with this one. With the new valve, the profiles are extremely variable. Some have a high degree of protrusion. Most of them, they have a limited degree of protrusion. The geometry is different. So I do not know if we can extrapolate what is published with a new valve to this Sapien.
Because the editing is finishing, still finished. But you will have it. So the next presenter will be
He's a character. He's a very, that is a very clever woman. Very, very clever.
Marina, why not? She's like that. Right?
Yeah.
Not good to marry her, maybe, but good to have her in the department.
Perhaps to work?
In the department? Yeah. No, she's good looking, but could be a bit the chief, huh?
It's too young. Probably with the age, it's going to change a little bit. You think not?
Not sure. Huh? Well, when I look at my mother-in-law, no, she's 98.
Similar to and it's similar to the one of Felipe, so maybe we can contrast a little bit or we can compare both of them. So my title is Challenging Our Expert. Shall we go a step further? My patient is a 83-year-old woman with previous hypertension and dyslipidemia. She had a permanent VDD pacemaker since 2014 due to complete AV block, and she also had moderate chronic kidney disease with a GFR of 40. And she presented in October 2016 with a 1-month history of increasing shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, and lower limb edema. Her physical examination revealed a weight gain of 5 kilograms, mild desaturation, increased jugular pressure, and 2 cardiac murmurs, systolic and diastolic, as well as basal rales and lower limb edema. On the ECG, she had sinus rhythm and electrostimulated QRS complex at 65 beats per minute. Here we have her chest X-ray, and you can see cardiomegaly. Yes, and you already see, that's right, what he said. Severe annulus calcification of the mitral valve. Here you see it as well, and the pacemaker. So we performed echocardiography, where we saw moderate aortic stenosis with mean pressure gradient of 30, an area of 1 square centimeters. She also had moderate regurgitation, and considering the mitral valve, she had moderate to severe mitral stenosis with severe calcification of the mitral annulus and leaflets, which had restrictive movement. The area was calculated with planimetry in the transagual echocardiography, and it was 1 square centimeter, mean pressure gradient 11, and she also had mild regurgitation. Last, she also had moderate tricuspid regurgitation with systolic pulmonary artery pressure of 80 millimeters of mercury. We calculated her operative risk, which was very high, Euroscore 2, 12.5, and STS 25%. So because it was the first episode of heart failure, because of the prohibitive operative risk and fragility, we decided to continue with medical therapy and very close follow-up on a monthly basis at the cardiology ward, day ward. She rested stable a whole year, and on October 2017, she presented with a 2-week history of decompensated chronic heart failure, due in part to new onset atrial fibrillation. And the echocardiography, we're going to see it now. There it is. We can confirm the severe mitral aneurysm calcification with moderate to severe mitral stenosis. She also had, you can see here, the regurgitation that had, it was worse now. It was estimated as moderate to severe. And you can also see the degenerative aortic stenosis. And here, it is not very well seen, but I assure you she had aortic insufficiency that was moderate to severe. And here you can see as well the severe aneurysm calcification. And last, this is the CT images, where you can confirm her MAC. And here, the most important projection, here you can see severe calcification. It is mostly posterior, lateral, and internal, and less prominent on the anterior part. Operative risk was similar as last year, 12.8% Euroscore 2, and STS 27%. So we stop here, and to be fast, because I think the other case is prepared, I'm going to proceed with the questions to our expert. And the first question is the following: would you consider the anatomy of this MAC suitable for a transcatheter mitral valve replacement? That means, is the extension and thickness of the calcification sufficient to guarantee a safe anchoring? Maybe we can do it stepwise, or do you want all the questions at a time?
No, we can. You can show the question and then we'll come back.
Okay, because
the reasoning should start a bit before.
Okay, okay. Then we can show the images afterwards if you want.
Yeah.
Okay.
So, high risk of LVOT, and then can you show the next one? Last question.
Yes.
Okay. Next question.
Yes.
Okay.
Well, regarding the patient as a whole,
okay.
if she would be suitable, and because she has also the aortic valvulopathy, what would you suggest for her?
And tricuspid, she has a severe TR?
Moderate to severe.
Okay. Okay, so that's not an easy case. This one too. And how is she doing at home? She's alone?
She's in functional class 2.
No, but I mean she was staying...
She's stable, yes.
No, I mean she was staying alone.
Yes, she's independent.
Yeah.
She takes care of herself at home.
Good.
And she's in like functional class 2.
And she's asking for something, or?
She isn't actively asking for something. No. She's doing quite well with medical therapy.
Yeah. Okay.
But yes. So.
Okay. So the first point, if you can. The first point is to know what is really the disease. She has a severe obstacle on the mitral valve or annulus at the level, atrioventricular level. There is something very severe, which plays a role in the pulmonary hypertension, plays a role in the symptoms, etc., no doubt. Now I'd like to ask a colleague, what about the aortic? Because she has a valve area 1, she has a gradient 40, but I don't see the cardiac the volume, ejection volume, because she may have, low flow, low gradient aortic stenosis. Exactly the group of patient, old lady, hypertrophy of the LV, etc. It's I would like to ask you, did you evaluate that, and do you have a CT of the aortic valve? Because it looks like it is calcified. It looks like it's really calcified.
In the short, I wouldn't be happy leaving the aortic valve without any treatment. I think it's important, and it must be. The ventricle is hypertrophic. I mean, small and hypertrophic, if you, I mean, you're going to get into trouble. And it's mostly the remodeling you would expect in a severe, yes, more than in regurgitation. So to me, it's a significant combined mitral and aortic stenosis, the main issue here.
I think this is a very interesting case because it illustrates the difficulty in diagnosis, in evaluation of the patient with several valvular heart disease.
Yes.
Tricuspid, you see it if you look at it, which does not happen very often, but aortic and mitral, and unfortunately there are very few papers to help. There is a group led by Dr. Unger who is writing position statement on this topic. They wrote a position statement in European Heart Journal recently, which comes after one written in Heart, but it is position statement based on blah blah, and that is the worst to me. It is accepted in European Heart because it comes from a very famous group working association, but it's based on blah blah. To me, the lesson from this is you could very well underestimate, because of low flow, the severity of aortic stenosis. Yes. So that's the point. So let's say I do agree with you. I feel, and CT will confirm that you have a CV and calculation of the systolic ejection volume will tell you, and CT will give you the amount of calcium. That's the two things. Now, what about the tricuspid is severe? Huh? Anyway, she has almost 90, so she has a severe mitral disease, and she has a severe tricuspid disease. Now she is really symptomatic, and you tell me that she is active, she is independent.
Yes, more or less, yes.
Yes, so we are a little bit out of the average. Is it worthwhile to do something for a lady with over 80? Well, she should be willing to have some treatment. I think she should follow you, the family should follow, etc. If it is the case, we have to see what we can do. I really do think that surgery, you probably discussed with your surgeon, surgery, forget it.
Yes.
With this age. And once again, the scores are misleading because decalcification of suturing to put a mitral valve is a terrible killer. It's not in the score. So she has local risk for valve replacement. So I think she's contraindication to surgery. So then, I'm sorry, no, it's easy, huh? If I put it here. But the point is, can we do something on this MAC with interventions? Mitral clip, no way. No way, because there is a mitral stenosis. Having a calcium in the annulus was considered to be a contraindication for mitral clip. But I don't know why. It is an extrapolation from the old data from the surgeon Alfieri, where they had worse result in the surgical Alfieri technique in patients with calcification. But what is the meaning? The meaning is we are not willing to put a ring in this patient. So it was comparing stitch, Alfieri stitch alone versus stitch plus annuloplasty. So this is not a contraindication per se for mitral clip. What is a contraindication is a mitral stenosis. So what do we do when we see that? First of all, we want to see if there is enough circumference covered. So you found a nice picture from, once again, Marina Urena. I would like, this one. So clearly patient A, go, because we have room to anchor our stuff. Patient B, go. Patient C, you have calcium, if I may say. The problem is, I don't want to lose my trouser. Huh? There is always calcium here. The problem is to have something here. This one, maybe there is something here. if we did it, we're crazy that day. Maybe we had this one. I'll be a bit reluctant, except if he had radiation. We did. I remember 1 or 2 patients who had radiation, the typical Hodgkin patient done 30 years ago, because it's extremely fibrotic and the valve holds. But in your patient, it won't be a problem because you'll put an aortic valve.
Yes.
So if you put an aortic valve, it is not the issue.
Previous to the
of course.
the mitral, yes.
Once again, if we plan a procedure, we should not do it on the aortic if we cannot do the mitral, because the mitral is too severe.
Yes.
It's too severe, really, which is seldom the case with TAVI. There are very few series showing TAVI and TMVR. Probably, well, there are very, very few. Very few. So we don't know exactly, but if you do, you should always start by the aortic stenosis. If you leave the aortic stenosis alone and open the mitral, you'll go to pulmonary edema. So you should start with the aortic stenosis and then do the mitral. But if you cannot do the mitral, you shouldn't do the aortic, because you cannot propose a good treatment to the patient. So here, the mitral is key in this patient. So we said the localization of calcium is not a contraindication, even more so because we are going to put a TAVI. Now, the other factors. Can you show?
You weren't going to put the TAVI. It wouldn't be suitable, this ring of this patient, because of the lack of calcium in the anterior part. If this patient didn't have aortic valve disease? Yes. If surgery is impossible, and if the anatomy is borderline, you go. I won't go. We publish that, but
We are hearing you.
Paco, are you talking? Because we are not able to hear you.
We are lost in the patient.
The risk of LVOT obstruction is a major issue, because as you saw in the series of valve in MAC from the US, multicentric, fatality is almost 30%, 28%, because mostly of this terrible complication. So, what could be a contraindication? Does this lady has a small LVOT, small LV cavity? She has. That's a problem. What is the mitral aorta angle? Well, we don't know. We need to have a CT to see that. Does she have elongated anterior leaflet? Definitely not.
No.
Definitely not. This is because we had one obstruction in our patient. I think this, we should add, does she have a very severely calcified anterior leaflet? It is the case here, because a severely calcified anterior leaflet could be an issue, could be really an issue, because it goes up, and you see, what is creating the LVOT obstruction? It is the valve pushes on the anterior leaflet, which go and occludes here. Then, does this lady has some septal bulge? You think so? So, yes, that's not good. And what about the bulky calcification of the subvalvular apparatus? I'm not sure she has.
I don't think so.
She has bulky calcification of the valve.
Yes.
So let's say this lady, we don't know the angle, but we have small LVOT, we have bulky calcification. So we already have two adverse factors, which is definitely not good. Which is definitely not good. So I'll be, I'll be reluctant. I'll be quite reluctant. Well, you have to do the CT. The CT is really good. But I think you have to re-examine the LVOT from the echo standpoint. So if you have a septal bulge, localized septal bulge, you may consider doing alcohol ablation a couple of weeks, months before. That's something we did in a few cases. It was published also. And you see a really fibrosis at the level of the septum, and then the patient may be a candidate for the procedure. So in this lady, for the time being, I think we cannot give a green light. That's my opinion. But
what do you think about doing the intervention only in the aortic valve? Because in the year 2016, she was okay with a similar mitral valve, and with the progression of the aortic stenosis, now she has symptoms. Could we try that or not?
You know, I think your point is very well taken, but she has a real stenosis. You know, she has a real mitral stenosis. So. Yes, that is a simulation.
Yes, that's because of the question
that is
of
done by Marina.
That's why.
You know the simulation, you see very well the patient's A, you have a septal bulge, B also,
yes.
But D is okay, E is
E.
okay,
yes.
D and E are okay. You have room, you see the room, you have room for implanting. But your question is very well taken. You know, but, well, I think the rationale is not to do the aorta, but if the patient asks for something, real pushes you, you may do that. But with 11 millimeter of mercury, mean gradient 11, you won't cure her. You won't cure her, really. But there is no precise answer. No precise. I would be probably reluctant. So here, what is that? That's the
There's a comparison between the two series, the American one and the European one.
You want to comment?
Very
that
brief.
is the bad one, the American one, and the one from Bichat, the good one.
The American one is only from MAC patients, and here we have valve, ring, and valve MAC. But you have the three columns separated. And here in the American one, you see the all-cause death 30-day mortality was 25%, and 1 year mortality 50%. And cardiovascular death was 13% and 24%. And what we already talked about, the LVOT obstruction is very important, and it's frequently associated with high death risk. And that's the European one. It was recently published. And as you see here, the technical success in the MAC people, that's what we're talking about today, well, right now, it's 78%. There was no death related to the procedure. And hemodynamically significant LVOT obstruction was found in 2 patients. And 30-day outcomes are much better. Death was 11% in MAC people. And that's important. This late valve embolization, maybe you can talk about it. Here there was no late valve embolization because in this series, for example, they had some cases of late valve embolization, of movement, of migration, and then the patients returned back with heart failure, and it was a big issue because then they had to treat that.
In the American one?
Yes.
Yeah, of course, yes. No, but if I want to comment, the cumulative is not very good, but the patients are so
but it was
sick, you know.
1 and 2 years. So
Okay. But if you look at the valve in MAC, technical success mostly due to the fact that we had to put 2 valves in several patients because the positioning is very difficult. When you have a valve in valve, you know where you go. You have the ring of the valve. When you have a ring, you know where you are. But when you have a MAC, you do not know exactly where is the most severe stenosis. And that's why we had to put other valves in several patients. I don't remember in how many, but we had to put another valve, either more proximal or more distal. That's not a fatality. There is zero fatality. Hemodynamically significant LVOT happened in 2 patients, and one requiring acute alcohol ablation, 1. The other one, we left her alone because you don't die with 50 millimeter. No surgical valve replacement, of course, it cannot be done. And late valve embolization, we had 3 cases, we had 0. It may happen if you undersize your valve. It may happen. Even in valve in ring also, may happen. We had 1 case, and we got the award for the worst complication at EuroPCR. We were very successful. The valve turn, etc. But it was a time where the 29 was available only transapical, and the patient went into cardiac shock before the procedure, and we had to proceed under ECMO. We went transeptally with a smaller valve, and it moved back. So, but slight lead displacement is a complication which should be known. It happened, and we didn't observe pulmonary edema. No. We observed on follow-up echo reappearance of MR. So because if the valve moves back, you may have MR.
Yes.
You know, you are out of the shirt. So that's a sign. That's why you should probably follow them very carefully. And we had also a couple of cases. Here you see the last line of THV thrombosis. And definitely I think the THV thrombosis in TAVI is a marketing issue more than a clinical issue, but the thrombosis in mitral position should be regarded as a very concerning issue, and probably will have to continue anticoagulation for long. We're able to resolve this thrombosis, as far as I remember correctly, by medical treatment, Coumadin, but that's something which might well happen, and really the is probably to give more 6 than 3 months of Coumadin.
And I think actually there are groups that recommend long life anticoagulation because of this problem.
Once again, I think it's very difficult to make a strong recommendation because you have no evidence, but I would suggest to do it as long as possible if the risk of anticoagulation is not very high. If you are in a very elderly patient, that's something you may discuss, because we didn't observe, as far as I remember, obstructive thrombosis. It happened maybe in 1 case, but always we got a reversal when using Coumadin. So it is easily treated, and when you have 1 case, you should, of course, afterward continue lifelong. So, sorry? No, that's, but it's, you know, I think it's the largest series in the world from 1 center, 27 cases. So we have to be extremely modest.
But I think one of the problems of the American group is that it was multi-center, and some centers only had like 1 or 2 patients operated on. So then the experience of the operator is very low. So the complications can be very high.
And I think there is also an absence of knowledge of the disease, because we saw some patient had balloon valvuloplasty before putting the valve, which shows that you don't know the disease. Because in MAC, you don't have any calcification of the commissures. So what are you expecting by ballooning? You're expecting to rupture calcium, because it may well happen. The calcium is not a nice layer of calcium. There are, pickles, a very asymmetric, very heterogeneous calcium. So I think you should not do that. There were plenty of, unjustified complications.
Okay. So many thanks.
Bravo.
Questions or comments from Salamanca? We are moving to the final case.
Okay,
in the meantime,
because I think this was a very complicated clinical case. We we don't really know what to do with this patient.
I will go for medical therapy.
Because she was an 83 years old woman, and it was 1 year out of the clinical course, so I don't know if the medical treatment is a good choice for this patient.
To me, clearly, I would stay with medical therapy, except if you have a very strong push from the patient, the family to do something. And in such case, what you say is not, I think it's not crazy at all, but you have to be cautious. And why did we get better results than the American colleague? Not because we are more skillful, because we rejected probably 70% of the candidates which were shown to us. That is the way. You know why the result? We are going to discuss that tomorrow. But
so let's move to the next case.
Okay. No
Enrique, adelante.
Sí, es que no sé si se oye.
¿Se oye?
¿Se oye? Sí.
Sí.
Okay. So thanks for waiting.
¿Oís a Enrique en Salamanca?
Hola.
Sí, perfectamente.
Vale.
Gracias.
Okay, thanks for waiting. I'm sorry we had some trouble with the editing of the video. So this case is a 60-year-old female with prior medical history of diabetes, obesity, and hypertension. She has also a moderate restrictive pneumopathy, and she has a history of valvular heart disease with a first intervention to implant a mechanical mitral valve in 2006, and then also a tricuspid annuloplasty. And last year, in 2017, she had severe tricuspid regurgitation, and it was decided to operate again and to implant a biological Carpentier 31 tricuspid valve. She also has an atrial fibrillation. She also has an atrial fibrillation, which was subjected to cryoablation in 2006, but then it recurred and is in permanent AF now. And also the heart rate control is very difficult. When she's not tachycardic, she's bradycardic, and this is causing a lot of trouble. So the current problem now is that she has had an early degeneration of the tricuspid prosthesis. The leaflets are rigid and retracted, and she has a mean gradient of 10 millimeters of mercury and also a severe regurgitation. She is symptomatic for heart failure. With severe edema, she's having like 100 milligrams of furosemide right now. All right, let's see if this runs. So, sorry. Here you can see at this point you can see the tricuspid valve, which is rigid and like retracted, and you can see the mitral regurgitation, which is severe. And these are 3D images of the valve taken by transesophageal. So this patient was discussed in a heart team meeting, and it was decided to do two things. First, to implant a tricuspid valve by a valve-in-valve procedure, and this has to be an Edwards 29 valve. And then to put a pacemaker, a permanent pacemaker, to improve the control of the heart rate of the atrial fibrillation. Because we're going to implant a tricuspid valve, this is difficult, and there's two options mainly. Well, three options. We can do an epicardial pacemaker. We can put a lead in the coronary sinus, or we can go for a micra. So our first choice was to do the valve-in-valve TAVR and then the micra. I don't know if you would like to make any comments, or you would have chosen something else. Okay. So this was our chosen strategy. Always local anesthesia and mild sedation whenever possible. Fluoro guidance, guidance whenever possible too. We decided for an echo-guided puncture of both veins because we were going to use very large sheaths, and then just do the valve-in-valve, and then after the valve-in-valve, the micra, and do a venous hemostasis with an X stitch. Okay, let's just go on. Okay, so here we are doing, sorry, I skipped too much. We're doing the echo guided, it's not working? Okay. Sorry. ¿Qué ha pasado? Yeah? So here you can see we're doing the echo guided puncture of the vein, and then we go. This patient was severely obese, and we almost couldn't reach the femoral vein, but yeah, luckily we managed that. And now we're going to go for the jugular vein, and here we are putting some anesthesia. And then again with the echo guidance, because the sheath we have to use for the valve is a 15 French, and then for the micra is a 23. So this is the internal jugular vein, which is dilated, you can see, and then in a second we go with the needle, and there's a lot of fingers there pointing, telling me where I have to go, but. Hopefully in a second I'll be there. Yeah. All right. So after that, yeah, we check the position of the wire to be absolutely sure we're in the venous system, and then we have to proceed with the valve-in-valve. Here we're positioning the C-arm so that the projection is perfect to see the ring aligned. And here you can see that we have in RAO we have a good view of the valve to go in. Right. So now we're putting a regular wire in. There you can see it in the right atrium, and then we have to cross, and we cross with a pigtail and a wire, and it was pretty straightforward. So now we are in the right ventricle with a pigtail catheter. I'm sorry. So after we place the pigtail in the right ventricle, we have to use a rigid wire. We have to use a high support wire, and we use as a phi wire, which is a pre-shaped pigtailed wire to prevent damage to the right ventricle. And then we also use this wire to stimulate the right ventricle, to pace the right ventricle, to help during the positioning of the valve. And here we are advancing the 14 French sheath into the femoral vein, checking always the position of the wire. All right, and now we are going to insert the valve, which is an Edwards 29, and we're going to advance it through the stenotic tricuspid valve into the ring. This takes a bit of pushing, and there's Paco pushing, and in a second you're going to see the valve appear on the inferior vena cava. Right, so there's the valve. The valve is not mounted on the balloon, so now we have to pull the balloon back so that valve and balloon are aligned, and we're going to do that in a minute. And then we're going to cross the ring, and we're going to implant the valve. Now we are positioning the balloon over the valve. Okay, so that's that, and now we're going to cross. And this is the crossing of the valve, which was pretty straightforward. Okay, so we have to position this radiopac marker right in the middle of the ring, and then we start pacing the right ventricle. and then we inflate the valve, and the valve realigns itself usually correctly. So you're going to see that in a second. Now we are inflating the balloon. And now we're going to fully expand it, and there you go. Right? So now it's time to check the result, and we do pressure tracings, and we do a right ventricular angiogram, which you can see here. We are injecting contrast in the right ventricle to see that there's no tricuspid regurgitation. And here are the pressure tracings and a pullback to check that the gradient is minimal. Right after that, we put another pigtail again into the cava. We put a wire, and then we have to advance a larger sheath, 23 French sheath, which is what we 27 French sheath, which is what we need to deliver the micra pacemaker. This is the sheath. You can see it, and now we're advancing it into the inferior vena cava. And we have to check by fluoro that the position is correct in the right atrium. And finally, we have to, there's the micra pacemaker, which is like more or less like a pencil eraser in size. And now we're flushing it, and we're going to insert into its sheath. We just have to flush and pull it back into its sheath. And as you can see, maybe in the image, there's 4 hooks that are on the tip of the pacemaker, and these hooks go into the right ventricle to prevent it from moving. All right. So there we go with the micra, and now it's time to cross the tricuspid valve. And this was a moment of stress, certainly, because we didn't know if it would go through or if it could damage the valve somehow. But luckily, after some pushing, pulling, and turning and fearing, we could make it go. And it was actually a little bit easier than we expected. This is a moment when it was a little bit stuck, but then it went through. And then we have to check. It has to be more or less apical and pointed towards the septum. So we inject contrast into projections to check that the alignment with the septum is correct. And then after we do this, there's here we are injecting the contrast. We do a little tuck test to see that it doesn't move, and then we release the sheath. And finally, this is the tuck test to see that the pacemaker doesn't move, and then it's time to move the sheath, do the X stitch to close the vein, and this is Dr. Latino doing the stitch, and then check the results with TOE, which was beautiful. No regurgitation, an average, a mean pressure gradient of 5 millimeters of mercury, and perfect positioning of the valve. You can see here the gradient, which was roughly 5 millimeters of mercury, and you can see in these beautiful images both valves, the mechanical mitral valve and the newly implanted tricuspid valve, opening perfectly, and that's the end of it. Okay. So thank you.
Well, I think it was a great procedure. I was very happy to be invited and to have a look. Yeah? No, I think that's interesting. Well, what can we say about this valve in tricuspid position? Once again, you have to really think twice before doing the procedure. It's useless if the right ventricle is dead. It was not the case here. The right ventricle was slightly dilated, but the function was not too bad as far as I took. You should be very careful and see if there is any dysfunction of the left mitral prosthesis. It was not the case. So it was appropriate to tackle the tricuspid. It's easier to do than the tricuspid valve in ring, which is a nightmare. But this one went well, and as far as we know, from limited number of patients, I think the largest registry is 100, maybe 200 patients worldwide. It seems that it works quite okay. These valves are very large, so the gradient are not a problem. Thrombosis, to my knowledge, they were not reported. The issues were the pacemakers. How to do the simulation before, but now with the stiff guide wire, you can stimulate on the guide wire during the procedure. And afterward, I think this is a very elegant procedure, but well, you were skillful and lucky, so that's good. and also we should, it's very high price. You told me the price. So it's a concern, but I think it was a very nice procedure. Very nice.
Thank you. So I would like to ask you, with these valve in ring tricuspid procedures, can you have the same issue with the right ventricular tract obstruction?
No. Well, is there any surgeon in the room? No, it cannot happen. The RVOT obstruction is almost impossible. Almost impossible because you don't have this anterior leaflet of the mitral, and the anatomy. No, it's not a risk. With the ring, the risk is dislodgement or dehiscence, because the ring are often a rigid ring. You cannot expand it like you expand the semi-rigid mitral, and also they are not complete, they are incomplete in order to avoid some trauma to the conduction system, but also they are not in one plane. They are not like that, they are like that. So it is very difficult to anchor and avoid tricuspid regurg. Of course, you can answer, well, if we lose the valve, if we have a remaining TR, it's not a major issue. But we published, I think, a couple of years ago, a follow-up and in a very large series of 5 patients, and I think 2 or 3 out of 5 had at least moderate TR. So it's a problem, and I don't see any solution except maybe putting plugs. But we never done that. But tricuspid ring is a very tricky issue. Very tricky issue. It's not very high risk like in the mitral, because if it goes backward, well, it remains the right system. But TR is a real concern.
Comments, questions?
Maybe one more thing. This is, I think, in my view, this is another of what you discussed earlier, that a risk score does not capture the patient. Mm-hmm. This would be a third surgery on the right ventricle for the patient, and the Euroscore 2 is like 6% or something. Would you have gone this way with this patient, or would you have decided anything else than we did?
No, I think you are perfectly right. No, we would have done the same. We probably won't have used the MICRA because we don't use it on a routine basis. So, but when I'm going back home, I'm going to send you people to have a look. No, I think you perform perfectly correctly. Now, I think the big step is pacing through the Safari. It really helped because before the Safari, we had to go with the sinus. And what we were doing is take a biopsy sheath and put it in the LV and pace in the LV with a pacemaker during the procedure. But okay.
I wanted to ask you on the first part of the story. This is a redo of a very, very early degeneration of a prosthetic valve. It was implanted a year ago.
Yes.
Less than 1 year. So have you ever seen such an early degeneration of a tricuspid biological valve? What do you think is going to happen in the future?
Thank you for the question. Yes, that's like the other cases. It's something extremely unusual. No, we saw that in mitral and in mitral position. I don't remember any case in our position, but we saw that in mitral position. And as you can imagine, surgical colleagues were very happy to send us the patient. And so we don't know about the pathophysiology, but they recovered. So we didn't observe the same phenomenon on the TAVI valve. That's what I can say. But I don't know. There were plenty of hypotheses, inflammatory stuff, etc. But we've done a couple in mitral position. And one died. One died. No, they did not recur the early stenosis on the TAVI valve. But we had one patient, she died during the procedure. It was very early experience in mitral position. The valve was slightly intra-auricular, interatrial, disoriented. And it was in the middle of the night because the patient was not well. And we had a lot of trouble to cross the mitral transeptally, and we pushed a lot, and she collapsed and died immediately without hemipericardium, but we probably ruptured the vein. Because, maybe you saw that when you do a mitral transeptal valve in a valve, time to time it's a bit difficult, and if you don't take care, you may have a bend on your Edwards valve, even more, and a bend in the inferior vena cava. And that's where we rupture. Yeah, inferior vena cava. So be very careful when you try to cross the septum. If you have resistance, don't push too much, because there may be a kink or something in the inferior vena cava. So so you pull, reorient, and try again. And if you can, because it could cost another device, if you can't, you take it off, balloon with a bigger balloon.
Do you think, Alec, that something related related with the surgical procedure can explain the so rapid degeneration of the valve?
Of course. It is a surgeon's fault, of course. No, really, I don't know. You should ask them.
And Javier, what do you think?
I don't know. I have no idea. It's very unusual. You do see it sometimes even in mitral, but it's very, very unusual. Maybe in Salamanca, have you seen such an early degeneration of biological valves in the right heart, or maybe in the left, in less than 12 months to have such a loss of tissue of the leaflets?
No, in my personal experience, I have never seen this follow-up.
And do you think it will happen again with this valve?
Good question.
Tell you next year.
The problem is we don't have any choice to do that. We have to wait and see.
Well, what I said, in our case, we had two patients like that in mitral position, and it did not recur on the TAVI in mitral position. But two cases, nothing. Yeah?
Okay, questions, comments?
So I have one question for Alec. It's related for the use of mitral clip in reduced ejection fraction. What's your experience of you have data in using mitral clip for mitral functional regurgitation in EF under 30?
Yes, okay, we are going to discuss that tomorrow morning. I don't know if you'll be you'll be with us? Okay, we'll discuss that. And my message is, please come to Munich to the ACS, where you're going to see the results of the first randomized trial, trying to explain to your question. And it's a very good one because it comes from France. And you'll see the results, and then you'll take your conclusion. But we are going to discuss that tomorrow, if you agree.
Okay. And another question?
Yeah, but in France, if I may answer, practically we can't do it in France because it's not reimbursed in secondary MR. That's
Okay.
it. So, second question.
And what's your opinion in tricuspid regurgitation after surgery in patients with pulmonary hypertension?
Well, as far as we wrote in the guidelines, it should not be treated. The problem is to know at what level. And I was in the 3 sets of European guidelines, so I know the way it happened. We are around the table. Usually the tricuspid come last or something like that. Everybody is exhausted. And the literature is so thin. You have nothing. So it's very difficult, but all the group was clearly in favor of contraindicating surgery on the tricuspid regurg if you have a pulmonary hypertension. If you have a patient with a severe primary pulmonary hypertension, of course you should not do that. If you have what happens, a patient we do after mitral with some degree of pulmonary hypertension, in the first set of guideline and second set, I was, I'm a simple person. My brain is very small. So we put a threshold for systolic pressure. And we said above 60, you should not do it. And now the last set of guidelines, there were people brighter than I, who said in patients with elevated resistances. But we are very careful, we didn't give any threshold. So now you have to play with that. And we were very hypocrite, because how do you want to measure the pulmonary resistance when using a Swan Ganz in a patient with severe pulmonary hypertension? All your measurements are stupid. Nobody does anymore the FIC, so the measurement of resistance is a bit, no, we don't have things. I think if you have a patient who is really good, who looks very good, with 65, 70, the rest is perfect, you may take a chance. If you have a patient who has very poor RV or other factors, probably better to avoid. But today the threshold we fixed was 60. But it's not logical, to close the tricuspid if you have a severe pulmonary hypertension. But some people send us patients, and have a practical question. You cannot measure the systolic pulmonary pressure in patients with severe TR from echo. So that's to us a strict indication for right heart catheterization. At least we can measure the level of pulmonary pressures. And when you are in such a situation, taking a big risk for the patient, I think you should do a right heart cath.
100%. Agree. We do a lot. This is a clear, and maybe Jaime is not going to tell you, but in our cath lab, we do use the FIC measurements for cardiac output.
The real FIC.
Yeah, the real FIC, but who is doing that in Spain? In France, I don't think we have any group.
Some groups.
We do also real FIC.
Yeah, some groups in Córdoba also, Barcelona also, some groups.
Okay, but some groups.
More questions or comments? So,
No.
not, we will close the meeting. Thank you very much, everyone. An applause for and many thanks everybody, and particularly many thanks to Alec. See you tomorrow, friends.
Okay, thank you for Salamanca.
Bye bye, thank you.
Bye.
Bye.